started. That was a great first panel, and we've heard some really interesting business approaches to issues of cultural competence and inclusion. And now we're going to focus on the domain of health. I'm going to keep my remarks brief. I'm Sonia Greer. I'm a professor of marketing in the business school here, and I learned that we have to finish by 12 noon. So we have a real expert panel here, and I want to make sure that each of them has an opportunity to speak, and we have time for some question and answers. So each panelist is going to talk for a maximum of 15 minutes, and then at the end we'll take questions. I'm going to give you the titles of their presentations, but I'm not going to read their bios. Given for the sake of time, they're in your books. First, we're going to have Carol Jimenez, who's going to speak about advancing health equity across the nation. Then we'll have Tarara Good talk about delivering care in diverse environments. And lastly, we'll have Erin Louvier talk about overcoming health disparities, the role of cultural awareness. And so we'll answer questions at the end, so please hold them and write them down, because I'm sure we'll have a very productive discussion. So with that, Carol, can you give a warm welcome to all the panelists.
Thanks very much, Sonia, and thank you for inviting me today. So, good morning. Again, I'm Carol Jimenez, and I have the privilege of being the Deputy Director of the U.S. Department of Health and Human Services Office of Minority Health. So just a little bit, and also I would like to introduce and acknowledge we have with us in the audience and I'm not going to get his title correct, but head of the project at our contractor who manages the website on cultural competency and cultural health, and manages the project, which enables us to do so much more in this area than we could do without their help. So Godfrey Jacobs at SRA International. Also Lena Marcino, who is here with me today from Office of Minority Health. So afterwards, if you have questions, you're welcome to talk to any of the three of us, and it'll all get back to the same place. So just first, a note about our office. We are the Office of Minority Health for all of HHS. And we do a variety of things. We coordinate the work of the other various offices of minority health. We're the lead office for racial and ethnic disparities and minority health issues for HHS and for the federal government. We do a lot of convening and collaborating with different federal agencies. I personally am the co-chair of a task force that has not only all the offices within HHS, but about 13 different federal agencies such as Justice, Education, HUD, Agriculture, the list goes on. We also give out a fair amount of money for demonstration projects in various areas, ranging from youth violence prevention, childhood trauma, reentry, outreach and enrollment for the marketplace, HIV/AIDS issues, Native American issues. There's a lot of information on our website and about what we do. But I'm here today to talk about one of our major initiatives and one of the primary focuses of the office, which is the national class standards, for the national standards for culturally and linguistically appropriate services for health and health care. So the national class standards have been around for about 15 years, and in 2013 we published an enhanced version with an enlarged definition of what's culturally and of what's cultural, and what different pockets. We enlarged the definition, and so now, and I think maybe as folks in this room know, people don't fit neatly into one single box. You take one person, they're not just Hispanic, they're not just female, they're not just gay or lesbian or transgender, Spanish is not Spanish is not universally the same in all different communities. So the idea is that we all fit in lots of different boxes, and we should be providing services in a way that's respectful and responsive to individual cultural health beliefs. So here, what is culture? It gives you a sample of the different groupings that can go into culture. And just as an aside, one of the things that our office does is we do a lot of work on data collection, what data should be being collected by different government agencies out there and by the healthcare world, and pushing towards disaggregation of data so that we truly do capture data by the various cultural groups, and it's not just these large pockets of racial and ethnic minorities. And I'm really, I thought I had a pretty short presentation, but I'm really going to speed through, so that everybody has a chance to give their presentations. So we have the national class standards, and they do a variety of things. And they're very fluid, they're very flexible, and we'll go through some of the national class standards and the overarching one, but it's really designed to be a fluid document of something that can respond to demographic changes. There's definitely an economic and business case for addressing, for providing culturally appropriate services in health and healthcare, as well as other settings. So, we've done an analysis, and disparities in health cost the U.S. an estimated $60 billion in excess medical costs and $22 billion in lost productivity in 2009. So if we as a nation and as communities were able to provide services in a more culturally and linguistically appropriate manner for the communities we serve, we would be able to save an awful lot of money in increased adherence to instructions, in reduced medical errors, in a variety of things. So, we think it's the right thing to do, but for those who need convincing, we have put together a whole analysis of why this makes sense economically for all parts of the healthcare system. So here again, some of the purposes of the national class standards. And I will say that, we couch them in terms of health and healthcare because we are the Office of Minority Health and we are in the Department of Health and Human Services. But really, they're designed to be very flexible and can be used in a variety of settings. The slide deck doesn't contain the standards themselves, but there is a slide that contains the website, www.thinkculturalhealth.hhs.gov, and we have the standards listed there. We have the blueprint for how to implement the standards listed there. The principal standard is just a general high-level standard of providing effective, equitable, understandable, and respectful quality of care and services that are responsive to diverse cultural health beliefs and practices. And then we go through standards for different groups, high-level groups of concepts. And the idea is that you can pick and choose what makes sense for your organization, for your field, in your situation. Not that in order to adopt and implement the national class standards, you have to do every single one and be successful at every single one. Take what makes sense, implement that, and then see if any of the others make sense following that. And I talked about the flexibility. So I know that in my time at the Office of Minority Health, that we're working with the State Department. The State Department's very excited about the national class standards and implementing it in the work that they do internationally. I personally have worked with the White House Task Force on New Immigrants, which is actually not focusing on health issues, but focusing on integration into communities and financial and economic issues. And they've adopted the national class standards is one of the recommendations as to how to help integrate people into communities. So it really is designed, and I know, some of you are in the healthcare field, some of you are in other kinds of fields, but as you work both around this nation in different communities, and as you work abroad in different countries and different communities, these are very appropriate, relevant, and adaptable standards. So what can you do with the national class standards? And we, again, we published them, I think the first publication was in 2001, and then the enhanced version in 2013. But one of the things that we've been doing in our office is a lot of evaluation of implementation of them. So we're evaluating it across a pretty wide spectrum of players to see where are we in this country with implementing them and how effective has it been. And so as you use the national class standards in the work that you do, we would like to hear about it. And one of the later slides tells you how to let us know. So here's just a copy of the cover of the blueprint. And again, you can find this on our website, and it walks you through how to implement it for your agency or company or office, or the work that you do. One of the great things that we do is, and again, thanks to SRA International, is we have developed e-learning curricula for different fields. And again, we focus on health, so these are different provider fields. So the e-learning curricula is free. It's online e-learning. And folks who take it can get continuing education credits in their state for taking it. And so we have these different e-learning curricula. We also have one for promotores de salud, community health workers, which is available in both English and Spanish. And so here's the website, thinkculturalhealth.hhs.gov. It's very easy to use. It's a wealth of information. And here we go. I also wanted to give a plug for National Minority Health Month. 2016 is the 30th anniversary of the Office of Minority Health. We were created as a result of the Margaret Heckler, when she was secretary, the Secretary's task force on the health status of racial and ethnic minorities. That's not the exact title, but we've been in existence for 30 years, working to reduce health disparities and achieve health equity for communities, and working with states and on a national level. So on April 7th, we're going to have a pretty exciting and high-powered health equity forum that will be live streamed so everybody can participate. And then there's ways, we have resources on our website. Our main website is minorityhealth.hhs.gov. And I know I work there, but it is a really great website. I use it all the time, even though I have the resources available through other means. And we have a lot of information and things that you can use in your work and download and link to. And we also have a really great listserv. We do weekly announcements with a lot of information, funding information from all sorts of sectors from all around the country, what different communities and states and federal agencies are doing. And if you go on to our main website, down on the left corner, the left column down below, you'll see it's very easy to subscribe. And that's it. So thank you very much. I know that we have a very short time, but we will be available afterwards if you want to talk.
Now we'll have Tawara Good from Georgetown University.
Good morning, everyone. I'm figuring out in my head how I'm reducing this time. So if I'm going fast, like my mother would say, like a New York minute, because that's faster than any other minutes, I'm apologizing in advance. So my topic really is looking at, okay, it's not advancing. All right, need some help here. Yep. Yep. No, we're missing slides. Okay, did they move around? Okay. Is there, like, I'm not sure what it's doing. Sorry. That's someone else's, so if we could just, it seems like it's stuck there. Um, let's try escape. This is like not fun. Which one is this? That's not yours, right? Oh, that's the best. These are all running. Is that it? All right. Okay. Let's get it from the, here, from here. And then I could just do enter. Yes, okay. All right, so my time's even less, all right. So my topic really is looking at the essential role of cultural and linguistic competence in healthcare. I'd like to start off quickly with rationale. There are many reasons why we think about cultural competence and linguistic competence in healthcare. I'm just going to go through these really very quickly. Demographic changes that we see in the U.S. And territories and tribal communities, the diversity of worldviews and beliefs about what it is to be healthy, what it means to be ill, and looking at wellness. We know that from clear evidence base that it improves quality and effectiveness and satisfaction with healthcare overall. There's federal and state legislation that's mandating cultural and linguistic competence across this country. We look at regulatory and accreditation mandates. And lastly, we know that cultural and linguistic competence have been proven effective in addressing racial, ethnic, linguistic, socioeconomic, and geographic disparities that we see within health, and quite frankly, behavioral health as well. One of the rationale that we included was looking at the current and emerging demographic trends within the U.S. This is data from American Community Survey, which is the most recent data update from the census. And as you can see, that we have quite a diverse population, at least by race and ethnicity in the United States. I would like to call your attention to projections then from the U.S. Census Bureau, that in the year 2045, that this nation, the United States, will become majority minority. I have an issue with that term. Only in America could a majority become a minority. But other than that, this is what the projections are. We know that the population under age 18 will reach this state by 2018, 2019, that's just simply around the corner. And then looking at the working age population that is projected to become majority minority between 2036 and 2042, really meaning that we have significant changes in the demographic trends that we see in the U.S. I'm going to just share with you definitions and conceptual frameworks for cultural competence. Before we can really talk about cultural competence, we have to really be in agreement in terms of at least what culture means. And really very quickly, we're looking at culture as learned and shared knowledge that groups have that generate how they view the world. And when I say learned, I think that's very important because as culture is learned, it can also be unlearned. And a lot of unlearning needs to happen within healthcare as it relates to cultural competence. Culture includes all the things that we see here in the ovals, and obviously many more that simply couldn't fit on this slide. It applies to a racial group, an ethnic group, a political group, a social group, and academic groups such as what we see here. I think what's very interesting about culture that there are traditions within culture that remain the same. They're passed down from generation to generation. However, there are also aspects of culture that are constantly changing. So we can look at this in a very paradoxical way. And so again, this is our concept of culture, and I'm making an emphasis on this because many times people in the US in particular equate culture solely with race and ethnicity. And so if we're looking at cultural competence, we have to really think about culture in its depth and its complexity. Again, another portion here, looking at what culture is, we obviously need to focus significantly on culture to really understand health, mental health, wellness, illness, disability, and end of life, because they're all culturally defined and influenced. This slide is quite busy, but I think it's very important in the work that we all do that would support people in health, because if we're not really healthy, we're not employed, and we're not really contributing to society. This is helping us to think about culture beyond the individual. It's looking at the complex and convergence of cultural context within healthcare, so that we can look at the patient, and then look at that person's cultural and/or multiple cultural identities that may or may not be shared with that of the family. Then we look at that within the cultural context of the community in which that person lives, and then the socioeconomic and political environment that may be impacting, say, for instance, in this country, currently immigrants has been significantly impacted by our political system. In the outer ring, we see all of the other entities and organizations that a person may need to access for healthcare. And so if we think about this, each and every one has its own culture, has its own language, has its own rules. And so as we think about the complexity of individuals entering our healthcare system and having to navigate and access all of these services, it can be very, very daunting. I'd like to define quickly what cultural competence is, at least as defined by, in 1989 by Terry Cross, Barbara Bazeron, Carl Dennis, and Marisa Isaacs. And one name that was not on a monograph that I like to acknowledge is James Mason. And so as we think about cultural competence, it really does require an organization to have a set of values, clearly defined values and principles. And that must be demonstrated within the organization's policies, within their structures, within their practices, behaviors, and attitudes. And it must be demonstrated in a way that people are able to work effectively cross-culturally. And I do say cross-culturally, not cross-racially or cross-ethnically. There are 5 elements of cultural competence at the individual level. I'll go through these very quickly. First, we have to be able to acknowledge cultural differences. Oftentimes, people have difficulty doing that. They feel uncomfortable. They may feel that they may be thought of being judged. And so that is an essential element. Another is being able to understand your own culture. It's very difficult to talk about understanding the cultures of others when you don't have a good grasp of what your own culture is. The third is to be engaged in self-assessment, and that can be from a very structured manner, but it also could just be simple self-reflection. Acquiring cultural knowledge and skills really says that cultural competence doesn't happen by osmosis. It is intentional, that there has to be deliberate approaches in which we are invested in acquiring knowledge and skills about populations that may be different than our own. And lastly, being able to view behavior within a cultural context. So no matter how odd a behavior may seem, it simply has a cultural context of which we may need to be aware. When we think about cultural competence at the organizational level, organizations have to be able to value diversity. Many organizations say it. It's in their mission statements. They have the photos on the wall. They have it in their brochures, but it's not reflected in the makeup of that organization, and particularly in the hierarchy. And so this is saying you have to value diversity in every sense of the word across all levels of organizations. Being able to conduct self-assessment. We have created some validated tools to measure cultural competence for healthcare and healthcare practitioners. Being able to manage the dynamics of difference, which is key and critical within any kind of healthcare organization or setting. Being able to embed or institutionalize cultural knowledge. Again, this is critical so that there's not the designated person within the organization that has responsibility for cultural competence, because it is everyone's responsibility in order to deliver this effectively in healthcare. And lastly, being able to adapt to diversity. And again, that's in our policies, procedures, and practices. Cultural competence, again, has to occur at every level of an organization, policymaking level, administrative, practice and service delivery level, at the patient, family, and consumer level, and at the community level. And I will say that much of the work that we've seen in healthcare has focused on the practice and service delivery level. And there are some gains that are being made at the policymaking level. However, that's what we see, and that's what's in the evidence base. I suggest to you that it's difficult to be a culturally competent practitioner in an organization that does not support you with policies, procedures, and resources, so that we need to work at each and every one of these levels. Very, very quickly, I would like to define linguistic competence. If we look at the linguistic diversity in the United States again, this is fairly significant. You can look at the percentages that are there and the language groupings that are there for each one. So while Spanish is indeed a language that is spoken predominantly in the United States, there are other language groupings that are there. I think this is really key and critical as we think about this in healthcare and, quite frankly, behavioral health as well. It's the category called limited English-speaking households, and this is defined by the U.S. Census Bureau. And these are households in which no person in that household over 14 years of age speaks only English or speaks a non-English language and speaks English very well. And so if we look at the households, it's 4.5% of households in the U.S. according to this data. Most recent data is 2014. However, we could clearly say, even with all the statistical things, that this may be indeed an underestimate. And so if you look at the Spanish, look at the groupings, while Spanish is 23.1%, Asian and Pacific Island languages at 26.5%. And so I think this is significant. It has significant implication for employment. It has significant implications for what we do in health and behavioral health care. So quickly, I'd like to define what is linguistic competence. It's a framework that we have come up with at the National Center for Cultural Competence at Georgetown. And it is the capacity of the organization and its personnel to be able to convey information in a manner that is easily understood. Typically, what we've seen is the focus on individuals who speak a language other than English. However, when we think about this within the context of healthcare, there are many people who have communication needs. This may indeed be people who have low literacy or low health literacy, or may not be literate either in their language of origin or in English. It also may include people with disabilities as well. And so we need to be able to communicate effectively with anyone who walks in the door, including the groupings that we just shared. We know that linguistic competence requires the capacity to address health literacy. And lastly, similar to cultural competence, it has to be manifested at every level of organization: policies, procedures, practices, behaviors, and quite frankly, attitudes. Because there are often times when people are encountering healthcare and they can't get interpretation services because someone decides, like, this person doesn't really need it, or they should just learn English. So what is evidence telling us about at least linguistic competence? We know that when people aren't served in their language of origin, which is mandated by law in the United States, that there's poor communication, incomplete and inaccurate health history, misdiagnosis of health and mental health conditions, misuse of medications, and the list goes on. This should also be of great concern to employers, because when people aren't well, they can't work. I shared this just to share with you that there's a lot in the evidence base around cultural competence, and this is a colleague, Glenn Flores, who's been prolific in terms of the research literature that he's contributed. And this is just a sample of the work that he's done. And this is only one pediatrician's contribution. We often hear that there's not a strong evidence base for cultural competence in healthcare. It's simply not true. I think people have not discovered the evidence. So lastly, these are characteristics of culturally and linguistically competent organizations. Time precludes going through all of those. But there are clear elements and performance measures that would correspond to each of these characteristics. And I'm going to end on this slide. This was done by our public health department in Oregon. They felt that they weren't serving all groups well, and they went on a process to really assess their cultural competence, make enhancements and improvements. This used to say, as a culturally competent manager, I ask that we modify this so that you can look at filling in the blank. And as a culturally competent, you fill in the blank. I'm capable of interacting positively with people who do not look like, talk like, move like, think like, believe like, act like, love like, live like me. I think is very elegant and is also a very powerful statement that epitomizes what is cultural competence. Thank you.
Thank you, and now we will have Erin Louvier from Whitman Walker Health.
So standing between you and lunch is usually not the best time slot, especially when we're running short on time. But I'm going to do my best to sort of highlight why I think I was asked to be here. I represent an organization called Whitman Walker Health, a community health center here in Washington, D.C., with 3 specialty populations: the LGBT community, people living with HIV, and people who have barriers to care. Those hopefully are coming back. Thanks. As she's sort of queuing up my slides, I'll give you a couple of things that are going on with Whitman Walker and a couple of facts. We have roughly 15,000 patient encounters a year. We have about 8,000 of those folks who are in regular primary or specialty medical care with us. Of that, about half are HIV positive and about half are LGBT. Those don't necessarily overlap, though some of them are. We recently opened a brand new health center and redesigned a facility around our integrated care model. And our model uses medical providers, behavioral health providers, community health workers, lawyers. And so our concept really is about getting the right care from the right professional, right place, right time, all of that. This, I think, are somebody else's. That's me. Yes. Okay. Perfect. Okay, great. Can I give you that? All right, great. Thanks. Okay, so I'm going to talk about kind of some innovations in service delivery that we have done to attempt to deal with health disparities among our population. Obviously, we are constantly on the path of learning and recognizing ways that the community has grown and the way that we ourselves, both as the workforce and responding to our patients in a positive way, how we've had to develop. So we have, we serve this very diverse community. The pictures, the first is our original home, the Elizabeth Taylor Medical Center. We moved all clinical operations to 1525 in May of this year, and as you will see, it's a gorgeous, brand new, light-filled building. We also have youth services, and we have our Max Robinson Center in Southeast. All right. So we could spend a long time talking about the barriers to care and the documented health disparities that the LGBT community and people living with HIV have traditionally faced. The bottom line is, their health outcomes are definitely worse, and much of that is because of stigma, discrimination, and kind of challenges and shame around kind of talking about sexual health and the ways in which even if a provider is receptive to treating someone, they often feel uncomfortable about having intimate conversations around sexual practice and other things that would really make a big difference in terms of applying what services that patient may need. Okay, so we built this brand new state-of-the-art health center that was designed around our model of affirming care and integrated care. We focus all of our professionals on having kind of doing the task that is most expert to them. So it used to be you kind of had in the HIV world, you had an all-knowing case manager who served as a therapist, a connection to social services, a resource for insurance navigation, lots of different roles. And our view is that that's too many things on one person's plate, and that these are very specialized tasks. And so our workforce has really evolved into, we have insurance navigators, we have referral specialists, we have behavioral health specialists, we have clinical folks. And I think the ability to recognize that these are very technical pieces has allowed us to make sure that it's sort of the right use of people's talents and skills. And so I'm going to highlight 3 of our program-related things that were implemented to attempt to address disparity that we saw in our populations. So this is our health center. This is a patient room, and the reason I show this slide is both it's this gorgeous light-filled, space. We believe like we have traditionally been a safety net health provider, but regardless of the income level of our patient, we want to be a place of choice. We want to ensure that people come here because they like us, they like our providers, they feel comfortable, and they get affirming care. This patient exam chair, it's lower, wider, and more accessible, so people of all mobility issues could use it, different than kind of the traditional long table. We spent actually a huge fortune to ensure that all of our restrooms in the entire building were gender neutral single restrooms. This is our icon that we developed related to that. And this was really, we don't own this building. We have a long-term lease on it, and this literally cost something like $800,000 extra to ensure this decision. But we knew that, part of being responsive and respectful of our community is that this is, what they feel comfortable with, and this is what people want. And so while that was, a expensive decision, it was the value-based decision that we needed to have. All right, so we talked a little while we were getting the slides up about our integrated care teams. And so we had 3 different issues that, that have recently kind of shifted the way that we practice. The first is around insurance navigation services, the in-person assisters and navigators under the ACA. We had a model for that care in 2007. Many of you may know some of our history. We were financially very close to closing in kind of mid-2000, and we really needed to relook at our business model. And some of those decisions were around how do we start to shift the way we think about payment and that sort of thing, and really being a place of choice, recognizing that DC has very generous insurance coverage, and how do we access that, both because it's the right thing for patients and it means their care is much more comprehensive, but also from a financial standpoint. So our insurance navigators are bilingual. They either have to be fluent in Spanish or Amharic, our 2 most diverse language groups. They have to screen all patients, and they help with enrollment and coverage issues. And basically that takes all of those coverage-related challenges, like I got denied for Hep C medication, or I couldn't get the gender-affirming surgery that I want because the insurance company denied us. These folks are supervised by our legal team, and they do all of the troubleshooting around those kinds of things, so that it's not a clinician spending clinician-level time, and expense, doing that. These are, $40,000 a year paralegals who are, well-trained and trying to, help do that. And if they can't do it or they are unsuccessful, it gets bumped up to the legal team to handle, a formal appeal with an agency. This was obviously really great for patient care, but also for the financial stability of the health center. The second is this red carpet. So when you think of that, you think of the Oscars, right? Like, we rolled out the red carpet, it was a glitzy, wonderful experience. People feel really valued. We realized that people with HIV were really struggling to get linked to medical care. They would test positive, they, would get some counseling, and then they would walk out the door. And many of them were then not connecting to the services and healthcare that they really needed. When they did come in, it often was a wait for an appointment because of kind of backlog generally in getting primary medical care services. And secondly, it was driven, those interactions were driven by like Ryan White demographic information and intake questionnaires where you had to go through all these different things. It often took 3 hours to complete that. Super unpatient friendly. And frankly, the results of looking at people in care were very, very poor. So we started to think about, well, what does the patient want in that moment? So they test positive, or they knew they were positive and they need to get back in care. They want same day service. They want immediate access to a provider, information, and their labs. Because the labs really are what's going to drive like the treatment and how they're doing. And so we rearranged literally our entire scheduling system and created a model where you walk in, and if you tested positive, this just happens for you. But if you walked in and said the word red carpet, no one asks you if you're HIV positive. That's our code word. You don't have to identify in a crowded waiting room in a long line of people. You just say, I'm here for red carpet, and people say, thank you very much, have a seat, we'll be right with you. And literally it launches an insurance navigator to talk to you about payment issues, a nurse to talk about any health issues that you have, a phlebotomy appointment to get your labs drawn, and a visit with your HIV specialty medical provider who shakes your hand and says, we're going to take care of you. You know, I'm really happy you're here. We're glad that you've connected to care, and I'm going to see you in a week to review your labs and make sure that you understand what's going on with you health-wise. That program, the city liked so much that it's now actually a requirement of any Ryan White provider to have some model of immediate access and appointments, you know, same day for getting people into HIV care. In 2008, when we launched this, only about 50% of the patients were actually linking and engaged in HIV care at 6 months. As a result of the program, we now have 85% of the individuals engaged in care and remaining in care at 3 months. So, you know, dealing with health disparities, obviously, you know, tweaking the way that we handle or respond to patient need has been a critical way that we are connecting and anchoring people into medical care that is so critical. And then the last this may be, you know, an area that some of you know some about or it's new, is we serve the transgender community, and there's been a significant increase in who we've taken care of over the last 4 years. When we started this program called the Name and Gender Legal Clinic, Gender Change Legal Clinic, in 2012, we had about 200 transgender patients in medical care. And what we recognized was that many people, the barrier was that their identity and what showed on their driver's license or other identity documents was not consistent with who they were. And so they didn't want to register at a health center where you have to hand over your document as part of the registration process, even though our forms and everything dealt with what's your preferred name, how would you like us to address you, what pronouns do you use. We had all the right lingo, but that was the barrier. They didn't want to walk in. And so we started this legal clinic where we help you change your legal documents. Your passport, your social security, your identification. And in doing that, we started seeing people come in, people who had never been connected to Whitman Walker, interestingly, given that that's our specialty population. And we assisted, since the start of that, we've assisted about 600 people with legal documents. Here we go. We had 200 people getting medical care. That was about 3% of our population. In 2016, we now serve over 1,000 folks for transgender medical care, and it's 12% of our patient population. The other piece is that this is fascinating in that the legal service is the gateway to healthcare. So when you look at all of the amazing health disparities for the transgender population, the thing that wasn't the most pressing to them were their bad health disparity issues and the fact that they were using street hormones or they were getting their care very sporadically. What mattered to them were their identity-related issues. You know, I can't get a job because I don't have a license that looks like me, or every time I try and go anywhere to a bar or any of those issues, I am stymied by these things. So we put that as the health intervention, which then allowed to build trust to ensure that we could bring them in to our medical setting. And most of them were like, you have doctors who know about what it is to be me and will help me figure this process out. And we were like, of course, come on in. The other piece of this is that, DC has been incredibly forward thinking around ensuring that gender-related care is covered in insurance. Despite that, there aren't actually enough providers providing the range of especially surgery-related services that are necessary. And there's still a significant amount of discrimination related to providing that care. So often, a provider may do breast augmentation or chest reconstruction surgery for biologically based females for whatever. Oh, sorry. And they will actually say, we don't have the services for the trans population. And so that's part of our model as well is, we have historically, through our work on HIV and now through our work on LGBT issues, we are fighting that discrimination both from a legal point of view, an patient and provider education point of view out in the community, and trying to develop relationships so that we feel confident and comfortable that the affirming care that we provide is being provided in specialty contexts outside the four walls of Whitman Walker. So I'm going to wrap up. There's a lot more I could say, but I think, it was really interesting to hear the different perspectives, this morning, and the way in which, I kept finding different ways to apply all of it, to the work that I continue to do there. The piece that I think I will leave you with are sort of two things. One is, our work is really around recognizing that healthcare is around the relationships that we develop, and that just like some of the speakers this morning talked about, there's no one-size-fits-all approach, and that even in the trans population, or our people living with HIV, or people who face all kinds of barriers because of homelessness and that, each one of those things is not who they are, and they are unique in both the needs that they have and the way in which they want to engage. And so, it's hard as a workforce development issue, to think about how to best train, and support staff, especially given, each individual is going to want something slightly different. And so our kind of value is patients first, and the second piece of that is really around a commitment to continuous learning, and that patient complaints or patient satisfaction data is not something that we're embarrassed about. We encourage staff to take that data and we take it apart and we figure out how we're gonna think about it differently, and much of that actually has driven a lot of the service innovations that we've had, and we engage, different groups like focus groups and that sort of thing to try to test out how is this going to make a difference. And as we move to being paid differently for the way in which we work, and that we're judged on the health outcomes that people have, the business case for why we care about all of this is pretty critical. You can't move the markers, on health disparities, and you can't move someone's actual, health outcomes if they don't trust you and they don't want to come in to see you. And so we see this both, as the right thing to do for patients, but also as a critical piece of our continued business case and survival long-term to ensure that we're here providing the care that people need and want in the way that they want. So thank you.
Okay. Thank you for a really great panel, and I really want to give the panelists another round of applause for doing that so quickly and imparting some really important information. So we have time for maybe just a couple of questions. I'm going to give up my privilege of asking the questions I prepared and just go straight to the audience. Amanda?
Hi, this notion of how do we train individual actors within our organizations to understand sort of structural dimensions that play out in the individual relations that they see in their practice as practitioners, as health practitioners in this case. And I'm curious, is that something that any of you are talking about, or is that something that comes into your practice in any way?
I think that there are a lot of different names for cultural competence, quite frankly. And I think that what you're hearing from NIH and this whole structural thing is another layer or another piece of an element of cultural competence. So if you're looking at the structure of relationships, that's still, in my opinion, being able to examine that in a way in which you still ultimately want to be able to be competent in healthcare delivery to whoever may be coming in the door. So there are a lot of different names. I didn't include that slide. There's like a truckload of names, including and concepts, including culture of humility. There are just many different concepts that are indeed emerging. I did a workshop recently with some surgeons, and they were calling it cultural dexterity because they felt that that was something that would resonate with surgeons. So.
I guess just to clarify, I think the distinction between structural competence and cultural, from the way I understand it, is that it's recognizing structured manifestations of individual behavior, right?
Right. So we can talk about this afterwards. I still think that people are calling things a variety of things and creating new things that would have intersections and similarities with the concept of culture as we defined it in terms of culture, so that we're looking at relationships and the structure of those relationships can all still fit under that umbrella.
And then you're next.
Hi. It seems to me in health that there are two things. That most people think health is good. It is a good thing. And secondly, that health, by and large, and there are of course exceptions to everything, is something that comes from people who are far away from the masses. They are knowing. They have more knowledge than the rest. So the dynamic of communication and listening becomes really important in the model of cultural competency. Would you say that it's more important than in some other areas, or is cultural competency and the frameworks for cultural competency the same across sectors outside of health? Same in business, the same everywhere.
Well, I don't know if this directly addresses it, but there's a lot that's dependent on the individual doing certain things and understanding a lot about what is going on with their own body and how they might achieve certain health goals that they have. And so I think this, person on high who gives directives and you're to adhere to them in some way, I think misses the point that you have to engage and empower the patient to really want to make whatever changes and understand and care about the goals that are going on. I think that is somewhat different than other industries in that it's very similar to kind of customer behavior anyway, like you're trying to drive change, but I think we're in a real turning point around the concept that empowering the patient and making the patient more the driver. So this idea that patient-centered medical home and everything revolves around the patient, I still see a lot of medical places, including some of the things that we do as provider-centered medical home. And it's like the doctor's at the hub and all of us are servicing the doctor, not the patient. And until we shift the lens that the patient wants to come in when they want to come in. That's why they use places like Patient First or the Walgreens or the CVS Minute Clinic. Like, we need to recognize that, open access and, quick, customer-driven, kinds of things are really what matters. Like, we treat it like you come in and you stay for an hour. Like, that's not what people want.
So do our models give us jail stays, the ones that are used in the health center? That's the question. Given what you just said.
I think that if we look at being responsive to culture, that means culture at multiple levels. It's not just what happens with the individual, but it's also looking at the culture of the organization. It's looking at the social cultural context in which people live. And I personally cannot say that I've witnessed a totally culturally and linguistically competent organization. I think that many organizations are at various stages along a continuum, and that they may be really proficient at certain things, but not so proficient in other things. However, that's part of the cultural competence framework, that it is indeed a developmental model.
I would just add that I do think, as we look at different sectors or different clinics or different provider groups or different plans that are implementing things like the national class standards and really trying hard to provide care in a culturally and linguistically competent manner, that they have made strides in improving the health of the community and in adherence to medical regimens. And so, I don't know that we'll ever be 100% there. It's an evolving thing, but I think that we are making strides and it is making a difference.
This is for Erin. This slide here about, can you give me a clear example of what is cultural humility?
I mean, I think the concept is really just this continued, like there's not an end result in the process to become culturally competent. It's that, you're never going to know everything there is about the individual that's in front of you, and recognizing that part of the interaction and the ability to do well by the relationship is an open and honest, kind of attitude that you're there to try to help them, bridge and get the services that they want, but that their experience is owned by them, and that we are interested in, hoping to help them get wherever they are. And I think it's sort of that process piece, not that there's an end result in how we're going to get there.
So if you want to delve more into cultural humility, look up the name Melanie Turvalon. She's a colleague, and she actually, she and a colleague actually looked at that concept, I want to say back in 1990, a good while ago, and has published extensively. And it really came from healthcare initially, when you're looking at physicians needing to be humble. And it really came from that spirit and from that place, and it has continued to evolve over time. Melanie Turvalon, Tervalon.
Okay, great. I'm going to take the last question myself, and I'm actually going to go back to the first question as a way to kind of think about this. I think embedded in all the panelists' presentations were some issue of structure, because culture is actually expressed in structures. And one of the things that happens in health, and there's a long literature on sort of blaming the victim or blaming culture as the reason for these interactions. So when we think about cultural competence, I'd love to hear each of your just thoughts on the role of structure in creating or contributing to or enhancing or supporting cultural competence.
So, it's funny because your question sort of assumes like adapting to others' culture. I think the idea of structure, but the idea of structure is whatever facet of society we take, there is structure. Society has structure, healthcare has structure, healthcare provider, the delivery system has structure, communities have structure, and the goal is to individualize it, but we need a mechanism to reach that and to help us get there. And so rather than each of us starting from scratch, we provide these different structures to implement culturally appropriate and linguistically appropriate care, because it makes it easier for people to take those initial steps and to get on the road to doing that, and then could individualize it even more. But I think it's helpful to, and what we found is having this framework out there has been very helpful, I think, to the healthcare landscape and communities. Because we don't have to, each of us doesn't have to start again.
I think that that people mean different things when they say structure, and I think that's important for us to be able to acknowledge. And so, if you look at the structures, and I'm put an S on it in terms of cultures, they're quite dynamic and quite numerous. And I think that in the context of cultural competence, is particularly the framework and model that we look at, one of the elements that it says that one has to be able to address is structure. And that could be the structure of a family. That could be the structure of the kind of structures that are in place within a healthcare provider's office. It also could be looking at structural racism and other kinds of things that we see. And so I'm probably fumbling big time with responding to this question, because I think that structure has to be placed within a context, and I'm not quite sure where to place that in generality.
And I think, especially like the red carpet and the name and gender change clinic that I highlighted as these ways that we took challenges we were having, and wanting to be better at caring for specific groups of people. I think it, for us, it's how do you build something that the system can, accommodate and make a difference related to that patient's experience. And I think the downside to that is all of the things that got said earlier, where you're not one thing, you're not just trans, or you're not just HIV positive. And I think, we continue to try to figure out how to have a structure that allows us, to move people through our system in a friendly and affirming way, but that, allows us to move them through so that they get where they need to be, but not kind of pigeonhole that experience as this is the trans clinic, or this is this. Like, you're here and we're here to provide a range of services, and you might be taking advantage of this one thing right now, but we need to build the ability to bridge lots of other ways that you may identify or needs that you may have. And I think that's one of our challenges.
Great. Thank you very much. If we could give another round of applause for a great panel.